So the bottom-up approach, to your point, this is where it's going to help. What it's going to help for the greater good. The bottom-up approaches can help segregate as to what that particular profile for that particular patient, what you call the group of sick and poor in a certain area or not, and who are not sick and poor, where we can come together from a policy and a government angle, to from a corporate perspective. What can we put in place that, to your earlier point, if we understand the profile bottom-up, what can be put in place or what solution needs to be put in place that we can come together that can help solve that particular problem?
And make money with people having healthier lives, and make money with, and so I think we're all in agreement where this is. Your lens piece is actually really important, and I think that, but what we're coming together is saying, like, how do we flip the script and being able to say, we're making money with people being healthier, then, like, how do we find ways to make money to make people healthier versus keeping people sick and poor?
How do you align this greater good with the incentives to do well? So it's like the doing good by doing well, and that's kind of what we're talking about. And I think when it comes to like insurance, you know, Dan started off talking about competition and having insurance companies kind of compete on lower costs, but you know, in some ways, I think part of going back to the Affordable Care Act, part of the impetus behind that was maybe flipping the script from how do you create a market in which, instead of insurance companies making their money by basically, because the rules of the road are not set up in a conducive way, they are making their money by denying people with pre-existing conditions, by denying as much care as they can. And how do you flip that so that instead they're competing and they want to take better care of the sicker patients, they want to take better care of the sicker and poorer patients, and they're competing on how well they can do that, as opposed to the other way. And that's not a moral judgment, it's like a, how do you set up the rules of the road to make that work? Is that fair?
And to that point, the one thing that I think everybody should keep in mind is, where are the insurance companies flocking to do business?
Medicaid.
They're flocking to Medicaid, Medicare Advantage, and large ASOs.
Guaranteed money.
Not because the profit margin is huge, but because it is stable and predictable. And they might actually be able to innovate approaches to manage to health. They're moving away from the markets where cherry picking gets them a profit, because it's not in the long run that profitable. So that's actually a good, I mean, could be one good thing that came out of this is, at least now you can say what the real drivers of insurance companies appear to be.
All right, thank you all for this. This got really lively for a Sunday morning. I think we're all finally, the caffeine is kicking in. I'm gonna let Eric ask his question, and then we'll wrap up.
First of all, is this working yet? Well, thank you all, obviously. In the last 5 minutes or so here, you probably obviated the question that I was going to ask, because you've kind of pulled everything together into really what the intent of this panel was and knitted it all into the whole framework of the last 2 days, which was great. I was thinking, you know, as I was listening, I think, well, gee, there kind of goes my question, because you're more or less framing it that way, except that I think where we ended up was actually with the question, as opposed to what the answer is to the question that I would hope we would get at. So I want to make a couple of comments on what you've said that hopefully end up as a question, and hand the mic back to everybody for one last quick go-round of do we have an answer to this. First of all, I have a slight correction. I actually didn't say I hate healthcare because it's complicated. I like healthcare a lot, as Sarah can tell you. What I said was that I was quoting all of the politicians I work with, that I think that, except for the few for whom healthcare is the real issue, and that it's a limited number, you know, they're mostly interested in jobs and education, and you talk to them about healthcare policy, and their reaction is, I hate healthcare, it's complicated. None of them really want to go near it. And we now have a president of the United States who kind of, you know, blurted that out. It turns out, you know, it is complicated, and gee, I don't want to deal with it. And I think, I don't think the president is unique in that. You know, I mean, virtually everybody I deal with in elected office, that's where they're coming from, you know. So no, I find healthcare fascinating. It is complicated, but I don't think it's too complicated to wrap your mind around. But I think the problem is, Sarah and I have been having conversations around this issue for 15 years. And, my real problem is that I think I know, well, I don't think I know, I pretend to know more about healthcare than I actually do. It's like the old TV commercial that, I'm actually not a health policy expert. I just play one as a consultant. Sarah's the one who knew everything, and I had to hand things off to her. I just do the kind of, the fancy framing it for the client. But we've talked a lot about this over the years, and I wanted to tie in a couple of things that you said of how I've thought about this issue over the years. First of all, this notion of what you were trying to do, Christy, when you were there, and we talked about this a little bit last night, the idea of making, essentially starting a business unit within the government to do this as a business. And that's not exactly the opposite of what I'm talking about. In fact, that's the flip side that I think, is the current that needs to run through everything that we're talking about. I think that there are business models that are emerging that will have to emerge to compete with, and in some cases, take the place of what have been thought of as traditional public services for at least the last 100 years, maybe not going back further than that. But the flip side of that, it's the thing with the Norwegian and Swedish postal competition. Businesses are in a competitive environment. They haven't had to think in those terms, but they are in a competitive environment. Other governments are figuring out how to poach their business. Businesses are figuring out how to poach their business. As that happens, the taxpayers, who are ultimately their consumers and their board of directors, are looking and saying, I can get better stuff elsewhere. I don't want to pay taxes anymore. It's not all just taxes, it's not all just race, all the things we think of as driving the rise of the right here, or at least the antipathy to the government. Part of it is government doesn't do a lot of things well. Most of us spend our careers around government, and we think it can be useful, but the more time you spend in government, the more you know how dysfunctional it is. So it's not surprising that consumers, / taxpayers look at government services and say, if I can get it better someplace else, I'm going to, and then I don't want to be forced to pay for it anymore. Anybody would say that. So governments need to learn to compete as businesses. And I mentioned that the term paper that I have my students do in the Future of Government class, they have two options. Most of them opt for design a business model to create a for-profit business to displace something government's currently doing. But occasionally, they'll take me up on the flip side of that, which is come up with something that the private sector is doing that you think the government can actually do better, and put together a more or less profit-making model to do that the government can do, outcompete the private sector, take the business away, and make a profit, or however you want to frame it, for the taxpayers, at least make it self-supporting. Most people think that sounds ludicrous. There are, in fact, government activities that generate a profit. The strangest example is the Postal Service clothing line, but there are things government can do to produce revenue in what it does. And secondly, there are plenty of things government can do better than the private sector. I think insurance is one of them. If you think of the backbone and app thing, if you're providing something that everybody has to be a part of, insurance is not a bad app to build off of that model. So there are things that government can do as a business, but as you described, the idea of doing that has kind of it's come and gone as far as the ACA goes. We have a new administration and a new Congress that aren't looking for how they can make the ACA work right. I've always thought they would never repeal and replace; they'll just repeal. Why they haven't repealed yet, is utterly beyond me. I don't think there's a replace coming. So let's assume that we do get to the point where we're not looking at, well, how can we make what you were trying to do in the government work right? But my question would be, in that environment where federal attempts to address health care after 10 years have finally collapsed back to the 20 years before that where they were going nowhere, in that environment, can you take the idea that you had, which is roughly akin to what we've been talking about for the whole weekend, and say there's got to be some business model for doing this. It's not brain surgery to say, gee, we can create a competitive insurance model. Could you go and start a business to do what you were going to do in the exchanges, which is essentially what I'm talking about doing that led to this conference. So that's part one of the question. Can you do that? I think you can, but in order to do that, you then have to get to what you all were saying at the end, particularly Jay, that you have to be in a world where the incentives are different, and where the incentive isn't how can you basically screw the patient, get their money up ahead, and then deny all treatment to them, but where making money comes from actually delivering value to the patient, which takes me to a comment that you made very early on, Manisha, that you said that you love capitation because if you've got this, you're getting a fixed amount, then you have to innovate and figure out how you're going to solve the problem. I don't know that I buy that, because in a lot of businesses, if you're getting a fixed rate to solve a problem, your goal is to get rid of the customer as cheaply as they can and not necessarily solve their problem. Your goal is to increase your profit margin. It seemed to me for a long time, and this is what Sarah and I have spent years talking about, and I think she's frustrated that I don't really know what I'm talking about. But, most things that you go into a professional to have a problem solved, you don't pay them to just spend their time and not solve your problem. You pay them to solve your problem. And if they're not solving your problem, you don't pay them. Why would you? Why can't we have a healthcare system where instead of where it used to be, you get paid for time and materials or something under a fee-for-service system? Well, that didn't really work out, so we decided let's do capitation, because that'll force doctors and insurance companies to make sure that they're treating patients better for amount of money. I think all that does is it means they want to reduce their costs, but not necessarily improve the quality of what the patient is getting. Is there a way, can we create a system where healthcare providers and insurers are making their money because the patient is healthier or remains healthy for as long a period of time? I think there are complications in that, but can we basically get to a system where you make your money because patients are healthy? So all that rolled together is my basic question for healthcare, and then how that fits into the larger thing. And with that, I'm going to turn it over to each of you to answer all that in 30 seconds, and then we'll wrap up.
So we're going to have another hour and a half, right? So
I just want to say one thing,
Yeah.
because you talked about capitation in the last one. And so here's the thing, is that capitation can give you that. That is actually, the capitation that we do is not to do it at a cheaper aspect. It's actually to innovate in a way that actually gives us healthy outcomes. So it depends on how you look at capitation. Where are you? I'm at CareMore Health. So my point is that, but I will tell you, as somebody who actually wants to, I deliver and care, and I'm the one who actually does the care, I love that the burden is lifted off of me, that I don't have to answer in fee-for-service world over exactly how and what and where I do something, versus the fact that I can actually be creative with what is being given to me to actually do this work well, and prove that you can invest even more to actually make it even better. And so I would argue that it depends on how you want to look at capitation, but on the ground, who actually does capitation and actually gets capitation, I would argue that burden has lifted off of me. You don't